Welcome to the second lecture on pulmonary function test interpretation. The first lecture covered a normal PFT. During this lecture, we will examine a patient with chronic obstructive pulmonary disease, or COPD. This is taken from an actual PFT performed at University Medical Center in Lubbock, Texas. The first item is the flow volume loop. Its shape is significantly different from the normal study we saw in Lecture 1. We will discuss this in greater detail during the next slide. The second item is the spirometry. The flow rates are abnormal in a pattern consistent with airflow obstruction. The third item contains the lung volumes. These volumes are abnormal in a pattern consistent with airflow obstruction. The final item is the diffusion capacity. The normal flow volume loop looks like a child's drawing of a sailboat. This flow volume loop has significant differences from that picture. The loop is shorter along both the x and y axes. The shape is different from normal in addition to the smaller size. The peak in expiratory flow is normal in shape, even though the height is less than normal. There is a nice sharp peak indicating a maximal effort. The sail constituting the expiratory limb is not fully catching the wind. It is a sagging sail. One term for this appearance is scooping. Note that the slope is much steeper early in exhalation than it is at the end of exhalation. If the scooping is sufficiently leftward, the FEV1 to FVC ratio will be reduced. This is the definition of airflow obstruction. If the scooping is late during the exhalation, the FEV1 to FVC ratio will not be affected or even may be increased due to normal FEV1 and reduced FVC. Late scooping can be seen in restriction or normal variance. The inspiratory limb is essentially normal. The peak flow is in the middle of inspiration. This ding in the rounded hull is of no significance. The patient may have had a muscle catch during the effort. The loop is nicely closed at the end of the maneuver. This ensures that there were no leaks or biases in flow measurement. I'm going to go through a little equation maneuver to demonstrate something. The slope of the expiratory limb can be shown to be the reciprocal of the product of resistance and compliance. Like the electrical analog, the RC product is a time, so its reciprocal is a frequency. The slope is the change in y divided by the change in x expressed as a derivative. I have used f for flow as I cannot easily make a v with a dot over it. Flow is a time derivative of volume. V is volume. I multiply the slope by 1 using the derivative dp dp as unity. This maneuver introduces the variable p, which is pressure. The product is then rearranged to give two recognizable derivative terms. The derivative df dp is the reciprocal of resistance. This is a definition. The derivative dp dv is the reciprocal of compliance. This is also a definition. The final result is that the slope of the expiratory limb is the reciprocal of the RC time. If the airways get smaller, then R increases. If the alveoli become floppy, then C increases. Both factors increase the RC time, which makes the expiratory limb less steep. The spirometry puts numbers to what we described as early scooping to the expiratory limb. Note that the forced vital capacity is reduced. There is a ventilatory impairment present. Note that FEV1 is also reduced. The reduction in FEV1 is out of proportion to the reduction in FVC. The greater proportional decrease in FEV1 compared with FVC implies that the FEV1 to FVC ratio is decreased. This is the definition of airflow obstruction. The decrease in midflow is a consequence of the decrease in all flows. There is no special significance to this term in this situation. The peak flow is greater as a percentage of predicted than the FEV1. This signals a good effort and is consistent with the sharp peak to the flow volume loop. There can be some confusion about the severity of obstruction. One cannot label the PFT as obstruction without seeing a reduced value for the FEV1 to FVC ratio. However, once obstruction has been identified, the severity of the impairment is best based on the percentage of predicted for FEV1. As obstruction becomes more severe and hyperinflation becomes worse, the stiffness of the chest wall can prevent the FEV1 to FVC ratio from decreasing further. As FEV1 becomes worse, the severity of impairment becomes worse. All classifications of mild, moderate, and severe must follow a deterioration in FEV1. I use a different scheme for categorizing mild, moderate, and severe than does the American Thoracic Society. I will present both schemes. Here is my scheme. I use 80% as the lower limit of normal, 50% as the threshold for severe impairment, and split the difference at 65% for the transition from mild to moderate. This scheme has worked well for me to divide patients into functional categories. Patients with mild obstruction will notice symptoms with heavy activity. Routine acts of daily living should not be associated with symptoms. Patients with severe obstruction will have symptoms with minimal activity, such as walking to the bathroom or even at rest. Patients with moderate obstruction will note symptoms with either extended walking or more intensive activity, such as cleaning or lifting. Here are the ATS guidelines. A diagnosis of COPD requires an FEV1 to FVC ratio of less than 0.70. This will pretty much be an inclusion criterion for all studies on COPD. This criterion will miss early disease in young people and overdiagnose COPD in the elderly. The boundaries for mild, moderate, and severe are different than mine. Everyone should be familiar with this scheme for the purpose of taking tests. Lung volumes increase as airflow obstruction gets worse. This is called hyperinflation. If the volumes exceed 140% of predicted, this meets the threshold for air trapping. This is an arbitrary distinction. We see that the total lung capacity is still within the limits of normal. We see that residual volume is elevated and is greater than 140%. This is consistent with air trapping. The usual pattern for COPD is for residual volume to increase out of proportion to TLC. This pattern raises the RV to TLC ratio. This ratio can be used to detect hyperinflation. I just look for a larger increase in RV as a percentage of predicted than the increase in TLC. Diffusion impairment is a late finding in COPD. Usually the ventilatory impairment will be worse than the diffusion impairment. The diffusion capacity in this patient is within normal limits. This system can correct for carboxyhemoglobin. This measurement is not made by the PFT equipment. It must be determined by blood analysis. Active smokers will have elevated carboxyhemoglobin, which will impair the diffusion of carbon monoxide and falsely depress the diffusion capacity. The alveolar volume is determined from the lung volumes in spirometry. The correction for diffusion capacity for alveolar volume will be discussed in Lecture 1. The correction for diffusion capacity was discussed in Lecture 1. This will be reviewed in the next lecture with a patient who has a low diffusion capacity for demonstration purposes. This concludes Lecture 2. Lecture 3 will cover restrictive disease.